All right, hello and welcome. My name is Maura Hamilton. I am a proud member of the class of 2015. And I'd like to say, really, thank you all for being here today. I've also worked with Jim and our planning committee on the 2018 Healthcare Leadership Steering Committee.
Good morning. Nice to be with you all. We're going to run through a little bit of the logistics, and then I'll have an opportunity to introduce you to our keynote speaker. I'm a graduate of 1971 and then stumbled around in different countries and came back. Faculty made me crawl naked through broken glass to re-up for my doctoral studies in '91. So it's great to be with you. I'll let Maura do a few more things before I talk about the introductions.
So this year also happens to be the 70th anniversary of the founding of the MHA Alumni Association. So what a better excuse to bring us all together here today to celebrate our past and forge a new future. Thank you all once again just so much for being here. Before we dive into the content of the day, there's a few announcements. First, please share your thoughts about what you're learning in real time using the hashtag MHA Symposium on social media and other platforms. Second, if you would like to receive ACHE credits today or long-term care administration CEUs, there's a table over there with students that can help you fill out the forms that you need to get credit. Finally, if you need to attend to work, make a call, just find a quiet place for conversation, please know that the Gateway Room is available for our group to use until 4 p.m. today. During the breaks and lunch, we're also encouraging our alumni to share their stories about being part of the MHA community through video. We'll have a student who is ready to capture your stories in that room. And then finally, we'd like to extend a huge thank you to our sponsors today, including Lumeris, Mercy Health, and Centricare. And then our sponsor, Genevieve, is bringing our live stream option to everyone who's joining us remotely. And also a welcome to all those who are joining us remotely.
Thank you. It's my pleasure to have the opportunity to introduce you to our keynote speaker, Barbara Young, actually Baroness Barbara Young of Old Scone. She has a Scottish background. I've known her for a number of years. She doesn't admit that in public usually, but she's also complaining that every time I invite her to address leadership and crowds in the healthcare arena, it's always someplace cold. She's bundled up and ready. I offered tickets for her to go to the football game tomorrow, and she's going to be declining that. Barbara started her career as a hospital manager. I first met her when she was a chief exec in the National Health System in England. She has a passion, however, to be a public servant in a wide variety of areas. Her career is summarized in the biographical sketch that you have in the program. I won't embarrass her by going through all those details, but I do want you to have an appreciation that she has not only been a tireless server of what is trying to understand the public interest and serve the public interest. She's now been, for the last few years, a chief executive not only in healthcare and not only in the diabetes initiatives that have been in the UK, and all of her activities are never just focused in the UK. She is looking at what is happening at the global scene and the interconnectedness that we have around the world. She's been very much a champion of the environment. She's currently chairman of the Woodland Trust. She's been chief executive of the Royal Society for the Preservation of Birds, which I gave her a grief for, and she said, "You cheeky Yank, that's one of the largest landholders in the world, probably, that's in the public sector." And so we've invited her to share some remarks with us about the patterns of leadership that are evolving and changing, not just in health, but in other sectors, because as some of you know, we have in the audience Lowell Cruz, who's been a very big champion to have a new generation of leaders that cut across sectors to look at not just being wise in the health sector, which are key for nations, but to look across many sectors. And so I hope that you will join me in a very warm welcome for our keynote speaker, Baroness Barbara Young.
Good morning. I want to start with a public health warning. I speak Scottish. So I'll go quite slow, but if you can't understand, stand up, wave, and shout, "Hey you, Jimmy," or some such appropriate cultural interruption. So let's start by thinking about what we think about when we hear the word leader and leadership. Are we talking about heroic and charismatic figures? Boadicea was a great woman in my view, an ancient British female leader who allegedly drove a chariot with scythes on the wheel to chop down her opponents. Attila the Hun also cut swathes across Asia. Napoleon was quite short. I think you're still allowed to be shortest these days, aren't you? He was only 5'2" tall. But he connived to put a member of his family as ruler of pretty well every European state, and he was a Weasley battle strategist. Nelson Mandela, perhaps you think of, gentle, saintly, wise in his latter years. Mahatma Gandhi with his philosophy of nonviolent protest. They come in shapes and sizes, these charismatic, historic leaders. You'll notice that I've deliberately steered clear of more recent examples, and those who might cause a bit of dispute here. I did not utter the words Fidel Castro, Martin Luther King, or indeed Donald Trump. Or do we think of methodical but inspired behind-the-scenes business leaders who've built commercial empires? Or research program leaders who've won Nobel Prizes and made major research breakthroughs leading huge teams? Or indeed, ethical politicians who've kept the wheels of state on in difficult times? I can hear people saying in the back of their head, are there such things as ethical politicians? But that's a different question altogether. My thesis for today is that we're seeing a significant shift in the task of being a successful leader, in health systems in particular, but in many walks of life. That the day of Boadicea or even Steve Jobs has passed, and that new leadership styles are going to be needed for the future. Now, I will just talk about my own background because that's where I come from. And Jim is absolutely right about his incredulity when I went to head up the Royal Society for the Protection of Birds, because I had done 20 years of my working life leading health services in the UK and being if I may be immodest, opinion former in terms of healthcare policy. I ran hospital, community services, primary care, and I was involved in planning and evaluation of services. But after 20 years, I decided I was going to do something completely different, and I went into environmental work and started at the Royal Society of Protection of Birds. And if you're going to start in a new field, why not start at the top, I say. So I was chief executive. My first statement at the interview panel was, you can't afford me. I don't know anything about birds. And apart from that, I missed the closing date by 2 weeks. But they still gave me the job, so there is right in the world. And so for the next 20 years, I led environmental organizations, both in the public and the voluntary sector, including a couple of environmental regulators. One of them is the UK equivalent of the EPA here, and also some major environmental charities. And in the spaces between these two broad strands, health and environment, I sat on some commercial company boards, was vice chairman of the British Broadcasting Corporation, the UK's public service broadcaster, and was also founding chairman of the government's quality regulator for health and social care, the Care Quality Commission. The worst job I've ever had in all of my life. And there's another story. So basically, I've been round the leadership block in the public and voluntary and private sectors, and I might as well admit now to the fact that I am actually the same age as the UK's National Health Service. We're both celebrating a glorious 70 years this year. That my mother, bless her memory, made a major miscalculation at the time of my birth and assumed that she would deliver me early. and so booked us into an expensive private nursing home for the birth. I came bang on time a few days later, by which time the NHS had been established, which would have entitled us to free obstetric care. But by that time, we'd already paid to go private. Ah, well, mother, better safe than sorry. So thinking back to my early years in NHS management in the 70s and 80s reminds me of a 1972 Carly Simon song, which I promise you I won't sing, no matter how hardly tempted. But the words go, "It was so easy then, holding hands without a plan." And that, to be honest, was pretty well what management and leadership in the health system was round about then. Standing up and articulating a vision and saying, "Follow me," went quite a long way, particularly if you said, "Follow me," with absolutely unmerited enthusiasm. So what did good leaders do then? And you need to remember this bit, as leadership traits, they're still relevant, but they're just not enough for the modern world. So there will be a small exam at the end of this section to see if you remember them. Well, first of all, let me use the words of our own dear heir to the British throne, Charles, Prince of Wales. He calls the first attribute of leadership the vision thingy. Leaders still need to ensure clarity of long-term purpose and a raising of the eyes of all to that horizon that we're all focusing on. Leaders then and now need to talk about and share values across their organization. They need to relish wearing their hearts on their sleeves and not recoil from showing that they care. They need a clear strategy, a plan for getting the vision thingy delivered. And increasingly over those years, they've had to ensure that it was developed in a bottom-up way, harnessing ideas from the grassroots of the organization and from its stakeholders. Then in turn, they had to ensure that it was embedded back down through the organization in the hearts of everyone in order to be delivered. In my experience, excellent leaders did this with stories and sound bites, constantly reinforcing everywhere they went and every process that was adopted the message of their strategy, using every opportunity and tool of communications, of objective setting, of performance management, and of review to restate the story, to restate the word. Good leaders were clear that outcomes needed to be measured. I always love that Woody Allen thing, 95% of success is turning up. But 80% of success is about implementation, and that means it's important to keep the score. And I always say that football would be a bloody awful game if you didn't keep the score. On a day like this, I just think football is a bloody awful game. But the reality is, if you don't keep the score, how do you celebrate success? How do you analyze and act on areas where performance is less successful? But it's important to keep the right score. In my first job as a hospital boss, I and my team were held accountable for increasing bed use, growing the numbers of patients treated. In reality, what we should have been held accountable for was keeping the population healthy and out of the hospital in the first place. Often it's at the point of devising performance indicators that you suddenly discover that your mission is actually rather different from what you thought it was. I always relish the story of the Women's Royal Voluntary Society, which is a charity that is a pillar of the British establishment. A comparatively recent charity for being such a treasured part of our national psyche. It was only established in the run-up to war in 1938. But it basically started with well-heeled ladies who lunch, graciously volunteering to dispense tea and support communities afflicted by war and emergencies and disaster. When it reconsidered its strategy round about the millennium, I think it probably had done that several times before then, but not in any real and radical way, it discovered that the biggest and most distinctive and valuable thing it did was actually to befriend older, isolated people in the community. So it stopped counting cups of tea dispensed and hospital library trolleys manned and started counting the number of older folk it helped stay successfully in their own homes. We all felt that it was a bit of a pity about the scones, which had been rather lovely, though the rock cakes were eponymous. But keeping the score is really important for leaders for that whole range of reasons, of inspiration, of performance, and knowing what it is that you're actually trying to achieve. Good leaders always knew that it's all about people. They spent their time in a very focused way, promoting champions at all levels, forging partnerships, signing up customers to share the vision. And it's vital to strategic leadership to have comprehensive training and organizational development in support of strategic objectives all through the system, promoting shared values and using a shared language. We used to have a technique when I was at RSBB, which I imported into the Environment Agency as well, of stuff called sheep dip, which we did right across the whole organization. In the Environment Agency, it was treated somewhat amusedly because, of course, we had a big workforce of guys on the ground who helped with natural disasters and built flood defenses and dug holes and ran rivers and stuff like that. And they were a bit, what in the trade is known as hairy-arsed. And nobody had ever really put them into any sort of touchy-feely training program before. But we did the sheep dip, which was really just to get the entire organization going through a common experience with a common language, talking about what they in their hearts wanted to achieve and how that fitted with the future strategy. And sheep dip, of course, is probably now not allowed in environmental terms except with rather inadequate stuff. But it basically means you drive the sheep through a bath, you hold them under for a while, they come out, they shake like billy-o, most of it flies off, but enough stays on to kill the ticks. Good leaders, of course, embrace change. I like to bring another environmental metaphor in here. In the days when thermonuclear meltdown was a possibility, and whoops, apocalypse might well happen, though with Mr. Putin and Mr. Trump around, who knows what still might happen. But it was alleged that if thermonuclear meltdown happened, that the creature that would exist long after the human race had succumbed to radiation would be the cockroach. And the comparison here is with the late lamented dodo, a bird which got its strategic options so wrong that it was doomed to extinction. It decided to become flightless and fat, and that seemed like an okay strategy on remote islands with no predators. But as soon as hungry man arrived and spotted these turkeys that had no means of escaping, it turned out to be the ultimate evolutionary dead end. And when I say dead, I mean dead. So, as good leaders, I urge you to embrace your inner cockroach. Be personally adaptable to change. Seek change out. Ensure your organization knows how to do change. For a while, I had the record in the British Health Service for closing and amalgamating more hospitals than any other single human being, which is nothing to be proud of, but it was about reshaping healthcare into more effective patterns. But I remember going around one of my hospitals one night, talking to the night duty staff, and this little lady came up to me and grasped me by the arm. She was an auxiliary nurse, and she said to me, "When I was at Princess Louise, you shut it. And I went to St. Columba's, and then you shut that. And then I went to St. Mary's Harrow Road, and you shut that. And here I am at St. Charles's, and I hear we might have changes here," she said. And I just want you to know I'm not objecting to change because I know how to do change, she said. But it would be quite nice if you were going to tell me what you're going to shut next. So knowing that people in your organization know how to do change and are increasingly comfortable with it is an important leadership task. So those things that I'm talking about are the sort of things you already know. They were the sort of leadership attributes and actions which were promoted then, and they're still highly relevant. But my thesis is that they're simply not enough in these days. Healthcare, in common with many areas of action, has new challenges that demands new styles. So I want to just explore briefly 5 big challenges for the future of healthcare that will have major implications for the leadership task. First of all, and I am a walking tribute to it, we are all living longer. And in many economies, the balance between young people and older people is altering. I've just come back from Brazil looking at jaguars, and there's a rule there, which if you're over 60, you get to go to the head of the queue for anything, which is quite nice. Wasn't too sure. How can they tell I'm over 60, I said to myself. But the reality is, it's not very many people, because they are a very young country compared with, well, certainly the UK. But the fact that we're all living longer, for me, is a bit of a worry. You know, it would be really great if you could opt to have those extra years of life in your 20s and 30s, not in your 80s and 90s. But as a result, healthcare for a greater population of the population that's got multiple chronic conditions is as much about social care as well as healthcare needs. And I thought it was very interesting when I heard someone talking about a trip they did here recently, where they had heard that Kaiser was establishing a 200 million impact investment fund for, amongst other things, affordable housing. So healthcare is much less about episodic care that are solved by single interventions, and much more about integrated condition management, chronic disease pathways, supported self-management, and social care. And we need also, in view of the rising age of the population and the fact that people are living longer, we need to start thinking very, very seriously and having a national conversation, in my view, about better ways to enable people to die at the end of their years in a way that they want and at a time of their choosing. And I'm campaigning very strongly in the United Kingdom for an assisted dying bill. I know it's not universally popular, but I think the time has come for those conversations to be necessary. How many people are there who, in the spring of their being, are quite convinced they want to have their finger on the exit button at the end of their lives? Very, very many. I talked about Carly Simon lyrics. I now want to go on to West Side Story lyrics. I'm definitely not going to sing this one. But for those of you who know West Side Story well, there is a song about Officer Krupke, and everybody's taking the mickey out of him because he says that they're delinquents and they say that they're socially deprived. And they go on about it's a social disease, and increasingly a bigger part of the healthcare dollar is taken up by managing conditions which have a social basis. This increased prevalence of lifestyle-related chronic conditions will bring a really sharp focus onto prevention. Now, when I, and indeed several people in this room, were first working in London on the first ever health strategy for a population in London, the borough of Lambeth, which is part of London, we commissioned the local professor of epidemiology to write a thought piece on what the health status of the population would be in 20 years' time. This was in 1978. He summed up his analysis with these very encouraging words: "The health of the people of Lambeth will never improve until they cease to abuse themselves with sex, nicotine, and alcohol." That was in 1978, the beginning of the AIDS epidemic, which is why the sex thing was quite as large as it was. Spool forward 40 years, and the sex thing may be less big, but substitute food for sex, as I frequently do, and we don't seem to have made much progress. Obesity, alcohol, and smoking are at the heart of most of the big, serious, expensive conditions: cancer, diabetes, heart disease. In the UK, diabetes is now the biggest single cause of heart attacks, strokes, amputations, and adult blindness. Care for diabetes and its complications now accounts for 10% of the UK health budget. Over 1 in 5 patients lying in a hospital bed has diabetes. They may not be in for their diabetes, but they sure as heck have worse diabetes when they leave, even if all they were in for was having their hip repaired. And yet we know that by reducing weight by 10% plus and walking 20 minutes a day exponentially reduces that risk. So if health services are not to be simply sickness services, We need to re-engineer them to ensure that they no longer seek to restore people from health conditions as cost-effectively as possible, but also to protect and promote health gain as central to healthcare. Leaders will need to know different things. They'll need to know how to engage with the wider social and economic determinants of health, including poverty, exclusion, and inequalities. Much of the healthcare focus will be on prevention and risk reduction, working with a whole range of players across primary and community care, in schools, the food industry, the drink industry, the leisure and activity industries, as well as people at risk, their families and their communities. A very different task. The third big challenge, I believe, is going to be technology. For many years now, technology has offered opportunities for new treatments and interventions, but the pace is just accelerating mightily. Increasingly, technology is being used for different sorts of interface with service users, including self-help support, navigation, concierging services. There's an app for everything. Big data is also being seen as a major game changer in research and solutions. Though bringing into operation the use of big data is not without its challenge. You would have thought that the British NHS would be able to have a head start on this. The NHS is ostensibly a nationwide system with nationwide data, and the UK has world-leading medical and bioscientific research and innovation capacity. We're really one of the world leaders in that field. But lack of join-up and increasing decentralization of decision-making in the National Health Service, and the fact that the National Health Service blew it completely in the early stages in terms of data confidentiality and ownership, have meant that the opportunities are being very slow to develop. The way they blew it was they assumed that 62 million people in the NHS would not mind their data being sold to an American healthcare company. When the NHS sold their data to an American healthcare company, people got a bit shirty about it. And so we've been set back on the road to being able to capitalize from that massive data which lasts for many years and is universal across the country. But we'll get there, But it will cause some challenges and some pressures for leadership that will be very similar, I think, to the ones you will experience here. Big data must mean big partnerships of organization to harness the vital breakthroughs for patients and people that big data can offer. And we're also, of course, on the brink of understanding how artificial intelligence can help address big data, decision support, and skills shortages. There was a recent PricewaterhouseCoopers study that concluded that over the next 20 years, artificial intelligence will do away with 7 million jobs in the UK. There are only 28 million people in employment in Britain, so that's big. And create 7.2 million entirely different jobs. They estimate that on average, 20% of jobs will be automated and that no sector will be unaffected. And we're beginning to see that. Robots are being used in social care. AI-assisted robotic surgery is improving quality and reducing costs. Virtual nursing assistants can be available 24/7 to answer questions, to monitor patients, to prevent hospital visits or readmissions. And the UK has committed to a major big data AI program for advanced cancer diagnosis, using algorithms to examine medical records, habits, and pool genetic information to spot people at risk and to establish trends. The future house may well be a healthcare provider. Using the Internet of Things, it will support us in keeping well and managing our health. When we get up in the morning and we look in the mirror after we've flinched, eye scanning will gather health metrics. I tell you, having your cataracts done at my age is brilliant, but my God, nobody told me I had wrinkles. So we'll have our irises scanned and that will tell the system something. The first morning pee will do our glucose test. The door handle will double as a blood pressure monitor. So this scale of opportunity and change will need a change on a commensurate scale in leadership and management approaches. And I believe that a particular responsibility of leaders will be the need to ensure access to services for those who, due to age, infirmity, or poverty, are less able to take advantage of technology. My fourth big challenge is affordability. I guess you're up about 18% of GDP now in the States spent on healthcare, and possibly 20% being signalled by the early 2020s. In the UK, we're at 9.9% of GDP, which is less than Japan, France, Germany, and much less than you. We're about similar to Canada. The OECD average is 9%. So why do we spend in the UK so much less, yet people aren't dying in the streets and everyone has got access to healthcare free at the point of use? Well, we have by chance stumbled onto a tax-funded system for the last 70 years, which rations on grounds which aim to be increasingly systematic and evidence-based. That very same system, though it has overhead costs that could be lowered further, is still fairly light on overhead costs. But the biggest challenge for us, and indeed for many health systems, is how to ensure that we go forward in using the health dollar as effectively as possible in the face of growing unaffordability. And there are many examples in the UK system of healthcare pathways and models of care which have been evidenced as providing the best health outcomes in the most effective way, but are still not adopted across the system. Now, you would think that the NHS would be able to do that. It's called a National Health Service because it's a national system, but we failed to crack the most effective way, in my view, of controlling costs by implementing best practice cost-effectively, system-wide. Variations in outcomes and costs from provider to provider and from system to system can be several-fold. Introducing a standard care pathway for diabetes care, integrating primary and community and secondary care, could have saved a calculated £1 billion from the NHS budget. £1 billion used to be a lot more than $1 billion, but alas, as a result of Brexit, it isn't anymore. That's the only thing I'm going to say about Brexit. Why is that? Why is that? I think we have insufficient focus on data and evidence, and we're insufficiently skilled in system redesign, and there's a lack of political leadership to say that we will only pay in the UK for standardized and evidenced good practice, not everybody's vision of good practice. We need to really drive for value-based care. We have a new initiative nationwide called Getting It Right First Time. It's underway, clinically led, working by clinical specialties to standardize across the whole system using best practice at best cost. I've got great hopes for that program, but it will require incredibly different sorts of leadership skills. And what are the solutions here? Accountable care organizations with the ability to deliver and plan and evaluate, payers in the lead because of the affordability thing, new players in the care coordination field. It will need sophisticated leaderships with groups and partnerships to collaborate in managing healthcare costs across services and across the value chain. And for heaven's sake, let's not call it innovation. We've all seen innovation initiatives before. I once heard it said that innovation centers are hospices where ideas go to die. We might need more innovation, but it would be kind of nice if some of the innovation we already have was implemented and spread at scale. Innovation for cost reduction alongside improved patient health outcomes, producing value-based care. My fifth and last big challenge is one that's really important in the face of all these others. And that's the need to ensure that the service user, the patient, the customer, however they want to be called, is at the center of standard setting and quality, and that their experience is central to decision-making about their care and about standards and design of care. The patient is no longer what it says on the tin. They aren't the patient recipient of care. They're in-your-face experienced consumers with in-your-face consumer power, and the internet giving them a wealth of information to trade with. And there are so many new ways of engaging with the patient experience these days at all levels of the system. President Trump isn't the only person who tweets. New leadership commitment to the centrality of the user voice, harnessing new skills in delivering that will be key. I'm just reflecting on the fact that in the good old days of STEAM communication in 2008, when I and my team were establishing the new regulator for the quality of health and social care in the UK, we made it a rule that no discussion or decision about the standards of care to which we would regulate or the way in which we would operate could take place without a service user in the room. So every day, there were teams of service users trolleyed into the buildings where we operated from, and they sat there in readiness waiting to be asked a question about X, Y, or Z. It was brilliant. I loved them. And they were people from right across the spectrum of care, including people with mental health problems, learning disabilities, people who had long-term conditions, people who had acute health needs. They were all there, and they were our sounding board and panel. And if there wasn't a service user in the room and an important discussion was happening, everybody would stop and rush off and find one. Now, it was very Mickey Mouse, and of course you don't need to do that anyway these days, because we've now got 5 years later, when I was doing the diabetes charity work, we had web-based chat sessions that brought users together from across the country to routinely engage around key service delivery questions. And now, these days, if I'm walking out of my general practitioner's surgery after a consultation, the app in my pocket will be asking me to respond to the question that is universal across the health service, the friends and family test. Would you recommend that service that you've just had to your friends and family? So there's no longer any excuse for putting the service user at the center of their care and the citizen at the center of their health system. So what does this all mean for leadership? Well, a lot. I think the days of the charismatic follow-me leader are over. I can't see Attila the Hun being terrifically good at cross-organizational negotiation. Though many of the traits we've already talked about for leadership will still be essential, they will not be enough. Excellent leaders will have skills in forging partnerships across systems and between systems. Leadership will be about bringing together new skills, hugely different skills from the ones we've ever experienced. Skills in harnessing data, geeky guys who know things that we will never hope to know. Skills in developing teams, skills in system re-engineering and in system integration. We cannot overestimate the changes we are going to see in health services workforce and across other sectors as the fourth industrial revolution rapidly emerges. Health and social care will not be immune, though we are perhaps some way off from the entirely robotic nurse, though one might say differently on the odd occasion when one's experiencing patient care. Multidisciplinary teams will need to embrace even more disciplines: epidemiologists, health planners, health improvement workers, alongside supermarket planners, schools administrators, community physicians, social media developers, a whole variety of people to tackle these broader societal questions. Most importantly, leaders will need to understand how to plan and execute sustained whole system change. And I think this, for me, is one of the key issues. That involves new ways of working, new technologies, new staffing, new training patterns, new performance indicator, new investment strategies. System change needs to be positive, premeditated, sustained. Now, there is a heartbreaking statistic in the United Kingdom NHS, and that is that the average length in post for a health service senior manager is 2 years. Now, what can you do in 2 years if what you're trying to do is revolutionize the system surrounding healthcare and a myriad of other commercial and not-for-profit and state functions? Nothing. So some of you folks who've worked for long periods in your healthcare setting have got much more chance of grasping those sorts of problems. You have the contacts in place, you understand how to work in the community, you know what the partnerships need to look like. So I praise US health leaders' stickability. I think you're streets ahead of us in that. All these changes mean that mission and vision need to be developed in different ways. They can't really be for individual organizations anymore. They've got to be system-wide. They've got to be about integrating and aligning services. And that will mean that diversity has got to be a really important issue. Leadership at both executive and especially at governance levels will need to be far more diverse. For a start, we simply can't afford not to sign up the brightest and best of talent wherever it lies in terms of gender, race, age, disability, for the crucial task of reshaping health economies. But apart from that, we need to ensure that that diversity of backgrounds and insights informs decisions and approaches, so we have at the table the widest possible range of necessary perspectives. I used to work with a whole bunch of Bengali ladies in the East End of London. Now, success for a traditional Bengali lady is getting your sons all married off so that you can have lots of daughters-in-law who move into your house, do all the work, and you just sit there. Part of that work is preparing impossibly sweet snacks for the mother-in-law. Since, as a good Bengali lady, you're not allowed out without a man, you spend most of your time on the settee being served hand and foot and given wonderful sweet-meat treats. A study of my Bengali ladies showed that the extent of their activity, and I should say that activity had a very conservative definition, activity was anything that involves standing up. And the extent of the activity of my Bengali ladies was on average 40 minutes a day. So they only stood up for 40 minutes a day, which was approximately the time to go to the loo, get dressed in the morning, get undressed at night and go to bed. So they got very fat, they developed diabetes, they went blind, their legs fell off, they died from stroke and heart attack, and their husbands and sons, though possibly not their daughters-in-law, were very unhappy. Our traditional health promotion activities failed totally to have any impact. It was only when we tapped into the grief of sons who'd lost their mums, and they found us some younger, more progressive women to work as health champions, that we began to make progress. Similarly, in the Sikh communities, the local temples are key. Though at my age, I have to get a dispensation from sitting cross-legged on cold marble floors. So diversity in staff and governance body is vital. Not every community can be represented, but diverse thinking is represented at round board tables, and it signals that diversity and diverse approaches are important. Universities and leadership development programs need to attract and unleash the potential of women and people of diverse racial, ethnic, and religious backgrounds. And leaders will, of course, need to ensure there's a transparency of purpose and process, to ensure that all of this has commitment from all, with staff participating and involved and able to innovate within safe boundaries, embracing a future of change and not feeling it. Training and development for leaders will need to support leaders who can foster collective responsibility and work effectively in group. And lastly, excellent leaders will be open to ideas from other systems. Now, I'm going to make a slightly racist joke here. I'm good at that. You know, you've all heard the one about, in heaven the police are British, the cooks are French, the engineers are German, the administrators are Swiss, and the lovers are Italian. And of course, in hell, the police are German, the cooks are British, the engineers are Italian, the administration are French, and the lovers are Swiss. You notice I've not insulted either Americans or Scots people. Mark Britnell, who was one of our leading health service managers, has recently written a book, In Search of the Perfect Health System. He says, the world doesn't have a perfect health system, but if it did, it would look a bit like this. The values and universal health care of the UK, the primary care of Israel, the community services of Brazil, the mental health and well-being of Australia. At this point, I began to remind myself of Mark's overwhelming sense of irony, but never mind. The health promotion of the Nordic countries, patient and community empowerment in parts of Africa, research and development of the US, innovation, flair and speed of India, information, communications and technology of Singapore, choice as in France, funding as in Switzerland, and aged care in Japan. So future leaders need to embrace the best from across the world and learn from other systems. I commend to you these ideas on health system leadership for the future. It could, as you see, involve considerable global travel. I hope you will find these thoughts that I've put forward today useful as you ponder on them. I'll go back to Carly Simon. It was so easy then, holding hands without a plan. It's more complicated now. But as leaders, we have, if we've got the courage to grasp them, more exciting tools in the toolkit and more opportunities to shape health outcomes for the future for the people we serve than we've ever had before. I hope you find today's conference inspiring and valuable. Thank you very much. God, they're fighting over me.
Well, we have just a few minutes. Giles, do you want to help moderate some of the Q&A?
I think we have a couple students.
Do we have microphones out there as well? Barbara, thank you. That was very good. You covered a wide waterfront. You've stretched our thinking and imagination, calling us to be more effective and to be more open for ideas. We have a few minutes. Let's see if there's 2 or 3 questions from the audience. If you'll just raise your hand, we'll have someone with a microphone run to you. I'm going to ask just one as you're collecting your thoughts. Barbara, I know that you've now applied leadership in a variety of cultures and settings. You very appropriately talked about the diversity that's so important to bring diverse thought and diverse backgrounds into the decision making. I can recall one of the discussions that you had when you did a day away, as you call it in England, the strategic thinking and the strategic planning. The question is, how would you as a leader invite that diversity of thought into the strategic thinking process when you're just going off with maybe 15 of your senior executives? How do you get diversity of thought at the early stages of planning and, of course, execution, please?
I'm a great believer in starting very wide, in reviewing or setting strategic direction. Because to be honest, the more people we have involved and signed up, the more easy it is to implement it in future anyway. And one of the great things is I once did a bit of strategic work with one of my organizations, and we worked for about a year to shape the strategy, and then we launched it. And the following day, when somebody came in and said, well, see that thing that you said we needed to think about? This is the results. And I said, no, you can't do that in a day. And they said, no, but we knew that was going to be important when we started talking about a year ago, so we've done it already. And of course, being a chief exec of a controlling nature, my first thought was, but I didn't tell you to do it. But it was great because it was internal. So I think some of these small-scale settings where you're bringing a small number of people together at crucial times have got to be informed by a much, much bigger process that really is reaching out to groups, using all of the techniques of modern communications and advertising and marketing to really just get ideas on the table, a sense of connection, an understanding of what people want. We gave up trying to determine what minority ethnic communities wanted from their diabetes care. No point in us thinking about it, they needed to think about it. So we instead employed a zillion healthcare champions drawn from the communities who basically did the work of going around community settings, groups of people, community leaders, and understanding, bringing back that knowledge. But you do need people in the small grouping that's going to digest all of that to actually have as diverse thinking and backgrounds as possible. Not for the sake of it, not because it looks good on the photo, but because they come from different places. You know, they come from hugely different perspectives. And that it's that agility of thought that I think is important at that. I used to call it the sinusoidal wave. I don't know, I'm not a scientist, so I haven't a clue what a sinusoidal wave is, but it's apparently one of those that goes up and down a bit. And so you go up and talk to staff, and then you come down and you talk to communities, and there's a crossover point every now and then when you just want to capture what you've got and start thinking about what it really means. And that's when the small groups are useful.
Any more
But
questions?
there is also a motto, and that is anybody around here who isn't confused, doesn't know what's going on. You know.
It's very true.
There is an element of muddling through.
We've talked to Barbara. She's going to be with us throughout the day, and we have a question back there. She's also going to be joining us tomorrow, not for the football game, but for the tour of the state capitol, and she'll also be joining us for the Hamilton Society dinner. She's agreed to spend a little bit of time off to the side when we take a break in a moment for more questions. Can you introduce yourself and then ask your question, please?
Thank you, Barbara Behrens. Rob Thames, what's one thing our country can learn from the UK about cost? We have an order of magnitude problem. Appreciate your insight.
You know a lot more about your costs. Until quite recently, we didn't actually know very much about our costs, and we rationed just on straight volume. We now know a lot more about our costs, but still probably not as much as you. So I think you've always had a lot to teach us. But, you know, it is the R word, it is the rationing word, and I know that that's a dirty word here, but the reality is, as a nation, can we afford to see huge proportions of the national wealth going in healthcare if some of that isn't being spent as wisely as it might and it's not producing the same leverage on health outcome? And I think that's the big debate you've got to get into. And we've got into it because we've got a dead hand controlling influence in Her Majesty's Treasury. He just doesn't let the health service spend anymore. So we've all then got to work like mad to get the maximum value from it. But I think rationing needn't be a bad thing. It's about not paying for stuff that really doesn't do much good, not paying for stuff that is less beneficial, not paying for stuff where patient choice, in our case, would discommode other people because they would get a bigger share of the cake and others wouldn't. And the big rationing thing for us now is the split between mental health care and other health care issues, because mental health care has been traditionally underfunded, and that is now being heavily challenged. And so that kind of rationing debate is taking place as we speak. But I think it's like me and the end of life, you know. The death thing is something that Brits don't like talking about, and we're going to have to get better at it. I think you're going to have to find another word, not rationing, but that's the word it's got to be.
Thank you, Barbara. Let's finish up this session. Giles, you'll come up in just a moment. But in the spirit of good exercise, I hope you will stand up and use 17 calories for a standing ovation for Baroness Barbara Young. Thank you.
Thank you very much.
All right, we're going to go ahead and resume. This has been a wonderful morning thus far. I want to thank the Baroness for such thoughtful remarks in her keynote, really highlighting themes about leadership and change that really transcend geopolitical boundaries. I am Jean Abraham, for those who don't know me, and I am the MHA Program Director. I am joined here.
And I'm Mary Ellen Wells, Jean's dyad partner.
Yeah, so we have a dyad relationship for leading the MHA program, And we are really fortunate to have the opportunity to impact this program today and in the future. This particular partnership actually began about a year ago, and really it's been working very effectively in the sense that we can leverage different skill sets, both in terms of curriculum and academia and faculty, and then the knowledge of the industry and the alumni network. So really being able to provide an excellent student experience. It's good to turn it on first. There we go. All right. So as we think about the goal of this morning, we're going to take a few minutes to provide an update of the program. And I always think it's important to start with mission. So if you come into the Mayo MHA offices, on the wall, you'll see a lovely plaque or glass etching that was donated by the class of 2013 that really highlights the mission of the MHA program, which is to develop professionals who lead innovative, high-performance healthcare organizations who seek to improve the health of their communities and advancing the field of healthcare administration, and to conduct research and disseminate that knowledge for the field. When we think about what distinguishes the Minnesota MHA program, I think there's really 4 key things. One, we are a top nationally ranked program in the country. We have a 70-year history that demonstrates that. We are accredited by CAMI, and not only are we accredited, but today we now serve as a mentor program to younger programs across the country so that they can also be solid performers. We pride ourselves, of course, on our alumni network. That's over 2,600 persons strong. And finally, I think that we distinguish ourselves by how the market judges us, in particular, where our students go and the trajectory that they take in their careers. We have been very fortunate over the years to be able to state that all of our full-time students are placed either in fellowships or jobs by graduation. And among our executive students, our metric there is those who change positions during their time. And in fact, more than half of our executive students are moving up the career trajectory while they are pursuing their degree. So for those of you who may not know as much about the program or have been away for a little while, we do have 2 paths to 1 degree. The full-time program having between 35 and 40 students typically on campus, 2 years, with a summer residency and clerkship in between, and really appealing to those students who are recent undergrads with bachelor's degrees with limited work experience. Our full-time students, as I said, most go into administrative fellowships, which has been kind of a historical pattern among our graduates. You can see on the left that where our students go, about 70% go to systems and organizations in the Midwest and Western United States, with others pursuing different paths across the country. Our students still predominantly go into healthcare delivery organizations, with integrated delivery systems being the most prominent. Our executive program, of course, dates far back, starting with ISP and kind of as the predecessor, and then in the early 2000s with the working professional program, and most recently in the form of the executive MHA. This January, we will launch our 10th cohort of executive students. These are students who have more work experience, who are looking for advanced training in healthcare administration, and who are working, so they need flexibility. And we do that through an asynchronous online blended program where students are here twice a year with the rest of their coursework online. Our executive students are, of course, even more diverse in terms of where they place, and about 40% are clinicians, so many are making a transition from clinical practice of medicine into leadership roles. The Minnesota model of learning, of course, underscores everything we do, and over the past few years, we've been working to kind of formalize our curriculum and think about very intentionally how we train students. As you can see, underlying everything we do is a theory-driven, practice-enabled approach to learning, where we start with the gray pillars, the core areas of knowledge and skills that we believe our students need, and then building upon those foundational skills and knowledge are additional skills in problem solving, innovation, and strategic thinking. And of course, overlaying all of that is an emphasis on leadership and professionalism. We've been working really hard, involving many of you in this room, around innovating our curriculum over the past few years. And some of those innovations include the development of a new professional development class for emerging leaders in the full-time program, population health, which will be deployed in both the full-time and executive programs, a revamping of healthcare finance and value-based payment, recognizing the changes in the system, more foundational coursework in quality, including offerings that will allow our students to take a deeper dive into methods and understanding quality across the continuum. And finally, a desire to develop more integrated coursework in innovation, strategy, and finance, given the linkages that exist in practice. And of course, we pride ourselves, this theory-driven, practice-enabled approach to learning is accomplished through the hard work and dedication of faculty that comprise both tenure track and tenured PhD faculty, as well as master's-trained senior lecturers and practitioner faculty who provide that important dose of real-world experience into the classroom. So we are pleased to have an increasingly diverse set of faculty who are interacting with our MHA students, both inside and outside the classroom. And I'd be remiss if I didn't mention the importance of the staff of the MHA program, staff who really work extremely hard to ensure a positive student experience for both the full-time and the executive cohorts. So let me turn it over to Mary Ellen, who will talk a bit more about the alumni.
Not only thanks, Jean. The alumni, and sometimes, are we the dog and pony, the brains and brawn? Captain and Tennille was the one I just heard. Take your pick, and then you decide who's who. Anyway, I'm so pleased to be here and looking out and getting a lot of hugs today. That, you know, if you know me, that makes my day. It brings me joy to be around such great colleagues and to offer this again after about a 25-year hiatus of having the Alumni Institute. We've changed it now, and it's the Leadership Symposium. But I'm here to just talk a little bit about how the program and the Alumni Association are so intertwined and interdependent, and that in 2014 we took a leap and we integrated operations between the program and the Alumni Association Foundation, where we have staff who are working on the behalf of both now. And that's when this dyad position was created. And it really does epitomize, this dyad relationship epitomizes what has existed for 70 years, but it makes it even more formal, and I think will be sustainable over the long run. The next, just a few of the, we're also looking at this position being more outward-facing and really engaging strongly with agencies and organizations that impact healthcare leadership. And Dr. Beebe is going to be talking a little bit about how we are really deepening those relationships in the field. And this is where I'd pause and say, we're one of the few organizations where ACHE gives this many credits for an event like this. And I think it's an example of one of the partnerships we've been developing. And with the nursing home credits as well, for people who need those credits. It's a great partnership that we're developing in many different industries. So back to the foundation and the Alumni Association. That's the mission with three main components. And it started in 1948 when the class of they started in 47, graduated in 48, and hence the alumni were born. This mission has been steadfast since that time, and with three main components: lifelong learning, engagement, and then philanthropy. It's really important that we recognize all three roles that the Alumni Association carry for the program and for our students. I want to point out and recognize the board members. Right now, you can see at the top the executive committee with Dr. Peg Van Bree as the chair, Pat Hayes, Jerry Carroll, Jenny Hallett, wonderful executive committee. And then you look at the people who are sitting on the board now and representative of the diversity of the members. When you look across the age spectrum, the gender, race, geographic distribution, and type of industry where people are working. So it's a nice broadly representative board that is working on your behalf. Now, we've got a couple of points I want to make about the work of the Alumni Association. One is really about how the program is really engaged in supporting, the Alumni Association is really engaged in supporting the program. We do it in so many ways. And now this picture was recently taken. It's of a room that's now, and students here who are here can testify that it's been wonderful to have additional space, that funding from the Alumni Association is able to provide more space for studying, for gathering, for all the teamwork that we do. You alumni know that we do a ton of teamwork, and to have the additional space really makes it beneficial for them. I just want to summarize, too, that there's two committees, the Engagement Committee and Education Committee, helping to have this body, this symposium take place. They also do webinars. They're involved with helping with the curriculum support. So that committee is co-chaired by Mark Enger and Molly Steffen, and we really appreciate all the work that they've done to really engage with the program and provide the support that we've come to really need for our students. We also have the Philanthropy Committee, and I urge, if you're interested in being engaged in that, please let me know. We've got scholarship support for students through the generosity of the Alumni Association, and we want to be able to stay competitive in the market, and being able to offer scholarships and support for faculty is tremendous, and that is a big part of what the Alumni Association does. So I hope that this brief overview gives you confidence that not only is the program alive, but it's very well. And we're really fortunate to have the faculty, the engagement of the alumni to offer mentoring opportunities, residency and fellowship placements, and just ongoing networking. I tell the students this, that I make a phone call to an alum and say, hey, can you talk to this student about your experience? Or can you provide some feedback? I never get a no. I never get a no. And it's being ingrained in the students who are on campus now. Their turn will come to pay it forward. So continue to role model, continue to provide that kind of support, and our degree will continue to be one of the best in the country. So on that, I'm going to turn it back over to Jean.
Excellent. Thank you, Mary Ellen. So now we're going to transition into the next part of our program, which is going to feature three faculty from the Division of Health Policy and Management. As you saw in our mission, one of the things that we do is conduct research. And as we do in this division, in this School of Public Health, we pursue research that has potentially large impacts, not only for the state of Minnesota, but the broader region, the nation, and the globe. And the research that's being conducted, of course, focuses on a broad set of issues tied to policy, tied to healthcare delivery and financing. And what we have for you today are 3 speakers who will share their particular expertise, in a practical way that allows you to understand what is kind of currently being investigated and how it translates into practice. So to begin, we're going to have Dr. Tim Beebe. He is the Mayo Professor and head of the Division of Health Policy and Management here at the University of Minnesota School of Public Health. Dr. Beebe's primary expertise is in the field of survey methodology, where he has a 30-year track record of testing new data collection methods in both general population and physician samples. His other research interests focus on patient-reported outcomes and measurement, developing and testing health measures, as well as investigating issues of policy and access for vulnerable populations. Today, he's going to talk about, I think, some of the new work relating to learning health systems, which is a form of health services research embedded in health systems. Prior to coming to the School of Public Health, Dr. Beebe was the chair of the Division of Healthcare Policy and Research, as well as director of the Survey Research Center within the Department of Health Sciences Research at Mayo Clinic. He was also the Deputy Director of Research for the Mayo Clinic Robert D. and Patricia Kern Center for the Science of Healthcare Delivery. Please join me in welcoming Dr. Tim Beebe.
Thanks. Thank you. Can you hear me? Is this on? Thanks for having me. I mean, whoever supplied that bio certainly must be full of himself, because it's a very long one. It's probably longer than my talk. Thank you for inviting me today to speak with you. It's quite an honor to speak with you, and thank you to the alumni for the support of the program, and to you, the students who had multiple options of different programs to attend, and for coming here. And I think you're among the best students I've ever come across, and I only say that to you because you're within earshot. So, no, it's just it's one of these jewels coming up from Mayo Clinic. I really didn't work much in the educational space, and one of the biggest surprises is this particular program, because it comports with what, my worldview on how we ought to engage as faculty with the healthcare system. You'll see a bit of it today. So my talk today is less around a topic or a substantive area like aging or Medicare, like Drs. Christensen and Shippey will be talking about. Mine's a little more agnostic. It's more of a process of research that reflects a little bit different tack that we take to kind of get at what Jean was talking about around translation of research into practice. Just a rough outline, disclosures, statement of the problem, what we are doing here within the division, within the school, a summary, and then Q&A. Help me keep track on time. I have a problem with that. And also I have a tendency to keep the button pushed on these pointers, so I apologize in advance for any retinal damage I will cause. So disclosure, I'm just fessing up. I borrowed the title from a session I attended at Academy Health in Seattle last year from the director of the Agency for Healthcare Research and Quality, Gopal Khanna, who pulled together a session with 3 CEOs and the Dean of the School of Public Health from Harvard to talk about making our research more relevant to key decision makers, such as those who reside in the C-suite. So I did borrow it. I'm not stealing it. I just don't want to be sued for using it. The other 2 are biases that I have. Not only that you'll need to know it to understand as I present this information, but they're motivating biases for what it is that we are undertaking within the division. Now, one bias is that I think that the health services research field and the division in particular we've always undertaken impactful work that instigates change at the policy level and at the practice level. But I think that we have a historical bias of looking at top-down solutions rather than on-the-ground guidance from healthcare providers, healthcare systems, and healthcare leaders. Those groups are so important in driving decisions at the community level, that it may be worth engaging them and seeking their guidance, and also equipping them as producers and consumers of research to bring about change at the policy level. In fact, I think it may be more effective than working through the legislative process. So that's one of my biases. When we do engage in practice-based research, I think that it's not positioned to provide the optimal impact that it could, and be relevant to the C-suite. The typical approach is this. So, I don't know which one you're looking at, but I'm doing the cat toy here. So, the typical approach, the problem of interest is kind of defined by the researcher, the academic. And the person approaches a healthcare system, convinces, cajoles, and maybe offers some resources to decide to get a healthcare system to participate in a study. So there's a decision to study it, the data are assembled, analyze data, interpret results, and the end product are journals, presentations, or maybe preliminary data to secure more extramural funding to do and broaden the research. I'm sorry to the camera guy if I'm moving around too much. So that's what we're typically trained to do. An alternative approach, to position us better to have more impact and to be more relevant to the C-suite is this, where the problem of interest is really comes from the clinical practice, largely. It can be negotiated. There can be some secular trends that the researcher brings in, but it's largely these are clinical questions or business imperatives that the practice is facing. Through a negotiation, there's a decision to study. You run through this same process, assemble the data, analyze the data, interpret results. You publish, but that's not where it stops. We continue on with the practice partner to deliver a tailored message to different stakeholders that exist within the institution, and then take action to change. In fact, the problem of interest really should be connected to this with the intent of making tangible change. So it's around this whole idea of implementation and dissemination science. The problem is that more passive dissemination of research has contributed to a lag between biomedical discoveries and their implementation to influence clinical care. Some have estimated it takes 17 years between discovery and application. But healthcare reform, payment reform, innovations in healthcare delivery, and the advent of health information technology and data really have forced fast-changing clinical context. In fact, did you know that by 2020, it's estimated that medical knowledge will double every 72 days? It has to be true. I read it on the internet. So that's up from 50 years sort of churning back in the 50s. So the rate of change is increasing over time. And so clearly, when you look at the context of a 17-year arc, that's glacial. And it hasn't gone unnoticed by healthcare leaders. There was a survey commissioned by the Patient-Centered Outcomes Research Institute and the Institute of Medicine, now called the National Academy of Medicine, back in 2015 of CEOs, healthcare CEOs, CMOs, COOs, and other healthcare leaders, and asking them about research. And they say that the leaders, the speed and focus of research is out of sync with these changes. They see the value of research in identifying important questions to help them meet their performance goals, collecting, curating, and making data available to support decisions, improve patient care, and enhance reputation and connections. But they do see that a more rapid iterative learning is needed to map onto the pace of practice. So ultimately, really, rather than 17 years, it's 17 months, 17 weeks, 17 days, 17 hours, maybe even 17 minutes. That's the churning that we have to equip and position ourselves to do. Ultimately, we want to land up to a system and processes and structures where evidence informs practice and practice informs evidence. That sort of recursiveness and reciprocity are hallmarks of learning health systems. And I'll talk a little bit more about that. The challenge, again, is our traditional health services training programs train us to undertake work in that traditional approach. They really don't equip researchers with the ability to embed and really engage clinical practices to undertake the work that I just described in that second figure. processes and structures. I mean, right now, clinical care and clinicians are siloed from researchers. There's not a lot of places to intersect to talk about priorities and strategies and things of that nature. So clearly, some sort of process and structure where connections can be made need to be developed. I want you to pay attention to those last two, because if I have enough time, I want to talk about a couple things that we're doing within the school that really address those two things. So just definitional clarity, learning health systems is a continuous learning health system where knowledge is derived from practice and is used to drive the cycle of continuous improvement. A learning health systems researcher is an individual who is embedded within a health system and collaborates with its stakeholders to produce novel insights and evidence that can be rapidly implemented to improve the outcomes of individuals and populations and health system performance. This is a general model, and maybe some of it might be hard for you to see. You know, again, what represents learning health system is this recursiveness. It's continuous. It doesn't just stop and then you move on to the next thing. There's a recursiveness in this. And so this is modeled in terms of like how research would look inside a learning health system. And it's patterned off a dyad model, not unlike what was just described by Jean and Mary Ellen. So it's a scientist-physician dyad, or scientist administrator dyad within there. So the entry point is here. There's an internal and external scan of what's the issue. You know, what are some of the problems that the clinical practice is encountering? What are some of the business imperatives that are facing that? The academic could come in with, you know, this new way of delivering care is being tried out at Cleveland Clinic or elsewhere. Let's maybe try it out here. Then the design, again, that's a negotiated agreement where it really has to be important to the clinical practice in order to move forward. The academic partner takes the lead in the design of it. In the implementation, really the practice needs to take the lead on that, because oftentimes we as researchers will introduce a level of artificiality. We'll bring in a grant, we'll cover some physician's time, maybe have a study coordinator, things that kind of are you know, requisite in you know, ensuring the fidelity to the protocol. And then when that apparatus goes, there's a reversion or regression back to what the mean is. And in fact, that survey I mentioned from Picori and the IOM actually mentioned one of the concerns of the C-suite is that we undertake work that perturbs or disturbs or disrupts the clinical practice. So really the work that needs to be undertaken needs to be dovetail with standard clinical practices. Then you evaluate, adjust your practice, and this is a big part of it too. So it's not just publications and presentations, it's talking to the stakeholders at all levels, C-suite, on down or up. And one of the things for the learning health systems to really work functionally is that there has to be sharing across health systems. You know, even the competitors ought to be sharing best practices. And that's more of a political challenge, but for this to work optimally, it really requires that sort of esprit de corps and common purpose. So the Agency for Healthcare Research Quality is one of our big funders in health services research. And they realize, as I said before, that the traditional training programs don't necessarily equip researchers with the ability to embed within health systems. And so toward the end of 2016, that gives you a sense of how kind of new this thinking is on the research side. They convened a series of technical expert panels and key informant interviews and fleshed out competencies, what a learning health systems researcher should be able to do what I've talked about heretofore, where being able to kind of engage and embed. So a number of these, I don't know if I did turn this off. Talk amongst yourselves. It's on the side. Oh, there we go. Thanks. Thanks, Jean. She's always bailing me out. So a number of these look like your standard health services research competencies. You know, research questions and standards of scientific evidence, research methods, informatics. But there are a few that really separate learning health systems research from your standard research list of competencies. If you want to know more, there's the article that describes those. So one is system science. training researchers to understand that healthcare systems are complex, understand that the different components of a complex healthcare system at multiple levels, how they interact and influence care delivery and outcomes. So it's understanding the financing and delivery and organization of healthcare, which is our bread and butter, but it's also applying systems theory and complexity theory to understand that these are systems, and you can't just look at one thing in isolation. They all interconnect, like the body. Renal function is related to your cardiovascular function, and that's related to the medications you're on, if you're fighting off sepsis and things like that. It's all a system that interacts. And so they have to understand, how to do things like simulation and data-driven modeling, but also organization theory and operations research, because we're trained to kind of, as researchers, sometimes isolate to attribute one sort of change to a particular aspect of an intervention, but increasingly we're doing these complex interventions that have multifacets and kind of being comfortable and able to understand the impact of that. So research methods, they'll be trained in the standard, randomized controlled trials, retrospective and prospective cohort studies, case control and cross-sectional, but also more nimble designs, like pragmatic trials, adaptive designs, surrogate endpoints, step wedge designs, and design thinking, more inductive and not as linear or hypothetical deductive as a lot of us are positive perspectives that a lot of us are trained in. So a new toolkit that can be brought to bear. Improvement in implementation science, improvement, everybody in this room understands that. Avoiding or controlling unnecessary or avoidable variation in care, but also looking at the quality of evidence and ensuring the uptake of evidence and organizational readiness to uptake evidence and adopt it. And engagement, leadership, and management. So part of what fails oftentimes, so I learned early on in my career when I did healthcare delivery, when I started healthcare delivery research, when a clinical department head would say, if I say it will be done, it will be done. And then if someone says that, you got to run, because there's no way. You have to get the buy-in from all levels. Leadership, administration, the patients, allied health. So it's really engaging all the players at all levels in the whole process. It's basically community-based participatory research, but within the healthcare system. Leadership, equipping researchers with the leadership skills and interpersonal skills to work with multidisciplinary teams and to talk to all stakeholders of all different levels, from the C-suite on down. Research management, again, getting back to the point of designing protocols and deploying protocols that don't disrupt or introduce a level of artificiality to the investigation so that the adoption is a little more greased at the end. So basically, what we're trying to do is equip researchers to undertake work that's more theory-informed and practice-enabled. And you might recognize that. I kind of co-opted that. That's the MHA program. I mean, there was just, Jean and Mary Ellen just highlighted that in their presentations. But learning health systems research, it goes beyond that. Theory-informed, practice-enabled, and methods enacted. And I'm going to trademark that. Okay, so that's kind of table setting. How am I doing on time? 15 minutes? Oh, wow. Well. Oh, okay. All right. I'll slow down. All right. Nature abhors a vacuum. So does BB. So we're doing a couple things here. Remember when I asked you to remember, the challenge that our training programs don't necessarily equip researchers to do that sort of work that I've just described. We've developed this program to get at that thing. The second thing is there's not a lot of opportunities for healthcare delivery and researchers to interact. There are instances of that, particularly in Minnesota, where a lot of healthcare delivery organizations have their research shops. You know, it reflects the ambidextrous nature of the healthcare delivery organizations within the state, that they have the core business, but they have the skunk works on the side, churning and innovating on the side. So the first one, about a year ago, the Agency for Healthcare Research and Quality and Patient-Centered Outcomes Research Institute combined forces and funds to develop this funding announcement. Learning Health Systems Mentored Career Development Program. The purpose was to train clinical and research scientists to have the skills to support and lead efforts, basically what I just talked about, that sort of researcher phenotype. So we scrambled and submitted an application, and we found out in September that we got funded. So we're one of 11 programs in the country that have been funded to do this sort of training program. So what is it? Again, the goals are to train a new generation of learning health systems researchers embedded in the interface of research informatics and clinical operations within the health system. So we submitted a call for applications, and actually they're due today. So it's training people, clinicians of all types, doctorally trained clinicians, as well as PhD scientists, in the philosophies and heuristics and methods that I just described here. It's going to be indexed off of those competencies I just ran through. So they get up to 3 years, 75% protected time. They get a stipend to undertake the work that they do of $25K per year. It's their individual development plan or education plan is really indexed on what their needs are, but it's heavily mentored. They're going to be sick of the mentors. The mentors actually have covered time to mentor them to do this work, and it's heavily embedded. It's heavily experiential. They have to be embedded with the different healthcare systems. In fact, as part of their application, they have to have a signed letter from the healthcare system that they intend to do their work in support of this. We want to promote and recruit advancement of these researchers, and we're going to be part of this consortium. It's a collaboratory, it's national, where we have like a national network of scholars, and we're sharing curriculum. We just had a great call yesterday of sharing curriculum across the different sites to train these researchers. So you probably can't see this, and I hate when people do that, but I just did that. So why put it up here if you can't see? But you can get my slides later on. This is what the Minnesota Learning Health Systems Mentored Career Development Program is. At its core are the University of Minnesota and two well-known learning health systems, locally, nationally, and internationally, Mayo Clinic and Hennepin County Medical Center, Hennepin Healthcare. So the University of Minnesota is a nice, acts as a convener. It has a lot of the coursework. We're an ideal entity to bring the different stakeholders together. Mayo Clinic brings, you know, a lot of innovation. They have the Center for Innovation that brings some of these design thinking principles to it. And when I was there, we developed a scholar program that looked very much like that, like what I just described. And Hennepin Healthcare, you know, again, a learning health system that serves incredibly socially and clinically complex patient population, but also has a center for patient and provider experience. So Neelay Shah at Mayo and Mark Linzer at Hennepin are the other co-program directors. So we have, that's the core. We have a number of collaborating clinical sites, Fairview, the VA, Children's, Ebenezer, Essentia, and Health Partners, who are to be engaged in the governance of this program. They supply potential scholars, mentors, and more importantly, as importantly, laboratories where the scholars can go play and answer some of these questions that come from the clinical practice. So the idea is that we wanted a representation of different types of patient populations, children, rural, aging, multiple chronic conditions, underrepresented groups. But we really wanted to treat the state as a learning health system, which it is. The state is known, and I'm sure you got this pitch with students when you were thinking about this. This is a state that has an ethos of innovation and collaboration that is really unlike any other state. This is tapping into that. It's trying to activate the entire state. Now, this is just the initial group. we've already had people approach us to be part of that, this learning health systems, like CentraCare. I was just blown away with what they're doing, and they're really quite excited about this. So if you're with a healthcare system and you want to play, let me know. So that's the education part of it. Setting up systems to better connect researchers with healthcare delivery systems in a more systematic way is part of this Learning Health Systems initiative. It's just a component of it. One component is setting up like a program or a core or a center in the spirit of our land-grant mission, really, which is really indexed off of engagement and translation. It'll be set up like a core. What does that say? 5? That's cruel. You did that on purpose. So I look like Mr. Magoo. So it's an intake process. You know, there can be consultation for people who want to undertake this sort of work. There are going to be workshops and primers on how to do some of the systems design and or systems thinking and the rest. Informal didactic offerings that are in existence now or developed as part of this program. What I'm most excited is this ideas contest. It's something we started when I was director of the Center for the Science of Healthcare Delivery. We called it the Practice Innovation Awards. And it was a call to the clinical practice. I think CFI did the same thing. Give us your ideas. You know, what sort of things are you encountering and addressing? And they would be submitted. We'd pare that down and protocolize a number of them. And for the winners, 2 or 3, they'd get $50,000 for 2 years to undertake this work, plus of all the intellectual horsepower that was around that. UCSF does something called the Caring Wisely, which is similar, but statewide. What we want to do in here is send that blast out to the entire state. You know, what are some of your big challenges? What are your big questions? You know, we don't want a fully blown specific aims page or a research question, which seems to be this black box for a lot of people. And then we'll look through those and say, you know, these are ones where we want to flesh out a little bit more into a protocol. And then we'll have a competition and fund 2 to 3 of them at, you know, $50K or more to undertake that work. Again, using these competencies and principles that I've just described. So that's drawing the healthcare delivery system into this apparatus and setting up some authentic and useful play dates between researchers and the healthcare delivery system. So we want to make it, again, available to health systems, payers, and policymakers across the state. Again, it's aligned with this notion that the entire state is a learning health system, and we want to be part of that. So in summary, leaders believe that integrating research within clinical care could have many benefits. The speed of research is perceived to be out of sync with fast-paced changes in healthcare delivery. Training researchers to better embed within the clinical operations is important. First step, that program I just described. And then elimination of silos, separating researchers and delivery systems is vital. So the work we have underway and planned within the school is intended to attend to the, man, why did I do that to myself? Attended to, it sounds like a Dr. Seuss book, above and ensure the relevance of health services research to the C-suite. That's it. Do you want me to go away, or?
No, it's
okay.
there. Around this way. So we have a couple minutes for questions from the audience for Dr. Beebe. Are there particular questions? All right.
I have 2 questions for you. First, are you connected with the School of Nursing and their development? Have you connected with the School of Nursing at the university with their effort that they're doing?
Along these lines?
Yes.
In the Benson Center?
Yes.
We hope to. It wasn't initially envisioned, but we're, again, activating a broader internal network with the medical school, which was initially involved in nursing and pharmacy. A number of our mentors, we have more than 70 mentors listed in the application. A number of them are from the nursing school.
Okay. And then the question, the second question that I have is that, and I'm not a pro of this, and so I'm asking this question, is that it looks to me the nature of research methodology is evolving in the country because of big data analysis and clinical modeling that's happening. So when it seems now that if you're a practicing person and you're trying to figure out, gee, why, what are the causes or the correlations for people spending so much resources for the end of life? And then they research using big data to do these correlations and then try to get some recommendations based on that. And the same thing that's happening with clinical work where, you know, like modeling drugs for cancers, and then they create a model and actually provide that care and see if it works. Okay, so does that nature of research methodology that's whole different than this kind of classic research, just kind of big data analysis, let's find the problems, and then let's research around what we find in this research. How does that relate to it?
Well, I think that's another tool. You know, deploying machine learning and big data analytics to data uninformed by what you're looking for. Is it kind of a needs assessment? You know, what are our segments that need most attention? But if it just stops there as opposed to what are we going to do about it, then I don't think that it really adds much or fits in it. To me, it's just a tool that can be used for a purpose that addresses a clinical question. If it's risk prediction modeling and you want to try that out within a clinical context, how do physicians and patients respond to a taxonomy that categorizes your level of risk, and what sort of treatment pathways are ascertained or defined based on where they reside? That's a learning health systems research question. But I see data analytics, big data, and the tools that are deployed like machine learning as one of the tools that can be used within the context of these larger questions. Like issues around, you know, pharmacogenomics and metabolomics and proteomics and transcriptomics, you know, as it relates to healthcare delivery. Now that brings in shared decision making. How do you talk about that? How does the patient and provider talk about that? That's a healthcare delivery system research question. So I think all of those undergird a larger framework. Some people see learning health system is just getting data together. And I just think I think that can be done, but if you don't have a reason to link the data, to analyze the data, to kind of go into it with some a priori hypothesis on how things might relate, then it's just a fishing expedition. You know, I think what puts the R in this activity is the research this part of it. What sort of germane theories and concepts can kind of frame this so you can understand the mechanisms why things relate to one another? How can you describe how to morph that information into clinical care delivery and optimize that to activate the patient and the provider as well? So I think what you're describing are tools that a learning health systems researcher can pull on, and I'm getting a T. I don't know if I answered your question. We can follow up later. I'm getting the cutthroat thing.
Very good. Thank you. I think in the spirit of staying on schedule, we're going to go ahead and transition. So before we conclude, let's give Tim Beebe one more round of applause.
Dr. Beebe, Dr. Christensen, and Dr. Shippey, thank you so much. I think that was really fascinating. I also know that this group has been listening for a very long time, so I'm going to be really brief. My name's Heidi Mastrud, and I'm the Director of Alumni Relations for the School of Public Health. I want to welcome you on behalf of our school. It is wonderful to see so many of our MHA alumni and friends here. I have the privilege of working with the MHA Alumni Board fairly closely, as well as with the Symposium committee that put on this event, and I am ever impressed with your enthusiasm and energy and willingness to show up. I just wanted to give you a couple logistics before we break for lunch. Lunch will be a break, so at 11:30, lunch is going to be served at your table. So if you're standing in back, I invite you to find a seat. There's full tables up front or nearly full where you can sit with your friends if you brought some with you. I also really wanted to ask you and encourage you to take some time either during our lunch hour or during the afternoon break to make your way to the gateway room, which is kind of in this hallway behind these first two rooms right here. In there, we're trying to capture some digital video archives of our alumni. And what we're looking for is really informal conversation about stories that you remember from your time on campus, whether that was 2 years ago or 25 years ago. Things that you learned in the program that you hope to carry forward in your career or that you have carried forward in your career. So grab a friend or go on your own. We have students in there ready to capture your stories. They can be as brief or up to 12 minutes long, but no longer. And then finally, well, not finally, if you are a vegetarian, you should have, or have special dietary needs, you should have a card in your name tag. Please put that on your table so that the servers know what to serve you. And then finally at 12:30, so from 12:30 to 2, and then again from 2:30 till 4, you're going to have your option of going to one of 2 breakout sessions during each of those times. One will be in the Johnson Great Room, which is to my left. The other will be in the Skyu Ma room, which is to my right. And so you choose the one that you'd like to attend. Once the rooms are full, if they get full, then please go to the other room where there's room for you. If you have any questions, our info desk will be staffed throughout the day, and we can't wait to have some time with you again at the end of the day after the breakouts. We'll meet back here at 4:15. Thank you.